Okay, you can start.
Go ahead.
Yes. So we will go direct to definition, sir. So my topic today is cellular therapy and administration. So point number one is what is cellular therapy? So as we know, cellular therapy is the transplantation of human cell to replace and repair the damaged tissue or the cell. So there are two types, transfusion and HPC. So in transfusion, like the cell that survive in the recipient for a short period of time, like example platelets or PCV. So HPC is the stem cell progenitor cell, and is engrafting, the cell is engrafted and replaced in the recipient like bone marrow. So next one is
Hello, Fika. You have two connections at the same time, and there is an echo. So one of the two, you have to switch off the microphone.
Yes, sir. So next is definition. There are three potency. So number one is topipotency. Topipotency is the cell can able to differentiate all the cell, and pluripotency is the cell can be able to originate cell of the different lineage. So next one is multipotency, is the cell to originate several ligands, and example hematopoietic stem cell. So definition, there are two terms of definition, stem cell and progenitor cell. So in stem cell, the stem cell can able to self-renew and they differentiate into mature cell, and progenitor cell is similar to stem cell but is more limited. So here there are few slides. So stem cell self-renewer is unlimited and progenitor cell is limited. So potentiality cell in stem cell is more multipotent, and the progenitor cell is unipotent and sometimes is monopotent. So maintenance of cell renewal in stem cell is yes, and progenitor cell is no. So hematopoietic progenitor cell transplant cellular collection. So here we will see the objectives. So identify the safety issue of the pediatric apheresis, and we'll discuss about the procedural assessment of collection of the HPC for the transplantation. And next is list the toxicity seen in the apheresis. So here we'll see the patient indication during the hematopoietic progenitor cell apheresis. So indication in autologous HPCT, lymphoma, solid tumor, and allogenic HPCT related to malignant disease and non-malignant disease. Malignant disease is like spreading disease, and non-malignant disease is not spreading. So next is sources of hematopoietic progenitor cell. So we'll see here the disease specification, protocols, and institute specific. Like this is a specification will collect the historic control protocol, like whether we have this protocol in the specific particle or the institution specific, like past experience, whether they have any past experience. So HPC donor evaluation assessment, and here we'll see that like the donor, whether like we want to do this HPC evaluation, will assessment the donor, and the donor should be like particle collection of the procedure, and in apheresis like growth factor administration we need so line insertion, and the patient he should be under anesthesia and the bone marrow harvest. So HPC donor evaluation, like donor testing, we will do all this laboratory testing for the donor, the HIV type 1, type 2, hepatitis and hepatitis B and C virus, HT, HTLV. HTLV is human T lymphotrophic virus, and CBC will do, and comprehensive chemistry like required for the donor eligibility, like blood grouping, pregnancy test, or CMV. So for the food and drugs administration, for the cellular therapy in the 5 requirement. So unrelated HPC donor collection, we'll see the pre-military searches, confirmatory actually typing, donor workup. So pre-transplant center is required for bone marrow or PBSC. So the donor decided if he or she want to donate it. If she or willing to donate, so we request the HPC products. So we'll do the informed consent and finalize the finalize of the process, like how much we want to withdraw. So cellular collection and procedure. So cellular collection and procedure, like cellular collection procedure in the bone marrow harvest and HPC apheresis umbilical cord we have, and HPC transplantation procedure, we have allogenic HPC, like donor lymphocyte infusion DLI and autologous HPCT. In cellular collection, target dose. So the cellular component target dose, like how heavily stressed the autologous patient, like has the patient had multiple relapse, if the patient has poor HPC, if the patient has poor bone marrow microenvironment. So protocol, like we use the HPC, whether the HPC transplant are planned, like how many we have planned. Does the patient like they need backup after the treatment or after the HPC post procedure? So the protocol required for the specific dose, and the Dutch HPCT program standard operation SOP, whether indicated for the dose, and individual HPC for the physician. So next we'll go for the cryopreservation. So in HPC product, autologous HPC required the cryopreservation, as we know, but allogenic we don't usually use for this cryopreservation except for the haplo or high risk patient. So the donor availability use, so unit cord blood and donor. So for the cryopreservation and the cryoprotectant.
Sí. Sento non posso parlare ora, mi dispiace. Hello, Fika, sorry.
Yes, sir, next slide. The bone marrow unique property. So establish the method of collection and the HPC sources. It is a quick procedure, and it is less for the chronic GVHD, and it compare with the PBSC. So in HPC collection, bone marrow harvest, so we plan for autologous, or it is autologous and allogenic. So this procedure, it should be performed in the OT under the anesthesia. So the procedure, we use the needle is in how to do the procedure. So we use, we'll insert the needle to the cavity of the rear hip bone or iliac crest. So several skin puncture of each hip and multiple bone puncture. So requirement of the dose of HPC is depend on the size or on the weight of the patient. So we concentrate as the HPC in the bone marrow, and usually collection and we infuse on the day 0. So cell dose will calculate as the protocol. So bone marrow harvest technique. So entry, it is the side, like we are doing the harvest aspiration, how we aspirate. So quantity, like how much we plan for the volume, how much we'll take, and the storage, whether we need to store or not. So bone marrow harvest associated donor risk, like in this is associated for the donor risk. So because of anesthesia, because the patient is going under anesthesia, so bleeding will be there after procedure and pain will be there, and infection, maybe they will have the infection if this from the side entry of the harvest, and some patient they will have this spinal pain, and whether the transfusion are required or not, we'll send the CBC and we'll see this whether they need to transfuse or not, especially for the donor like the small donor. So post-marrow harvest nursing assessment. So we'll assess the bleeding, or whether the bleeding is there or not. So we'll put the pressure dressing and we'll do the dressing, whether if the site was oozing or bleeding is there. So we'll measure the vital sign and we'll send the CBC after post-procedure. And for pain, we'll give the analgesic, analgesic to relieve the pain, and prolonged pain may be required for the follow-up. So post-marrow harvest nursing intervention, like we apply ice pack intermittently, we reinforce pressure dressing and administered analgesia was required, transfuse as necessary, and anti-persitory guidance. HPC collection apheresis, autologous and allogeneic. So, and this one is non-operative room environment, no general anesthesia, required for mobilized for all the patient for autologous chemotherapy and the granulocyte GCSF, and for allogenic we need GCSF. So PBSC unique properties here. This PBSC we don't need for general anesthesia during the procedure. It is fast and faster in engrafting. So it is decreased for the tumor contamination, and it is the risk for the chronic GVHD. So pediatric donor challenges, patient preparation, we'll see achievement, maintenance, adequate vascular access, how to assess this venous catheter and maintain intravascular volume, how much we want to do. Pediatric affairs unique challenges, venous access, central line or venous or peripheral access, we'll see the toxicity of management, the electrolyte management, especially the calcium, and intracorporeal volume changes, they will have this hypovolemia. And for the safety, we'll educate the patient and we'll do under the multidisciplinary and the child life music and the therapy will provide. For the access of this venous access, so central venous catheter CVC. So we plan whether it's temporary or permanent. So we'll send a high flow rate required. So the catheter, it will be the large of 2.0 mm diameter large pore lumen with the suitable of the apheresis, we'll see. So less than donor require the catheter. So maybe they require for the dialysis or apheresis catheter. So the blood vessel for the choose or femoral or will choose for the femoral or the internal jugular vein. This one we may require for the surgeon to insert. So pediatric apheresis toxicity management, they will have this hypocalcemia, they will have low potassium, and the management will give the calcium because of hypocalcemia. So we may require this calcium rich diet after procedure, during the procedure, and the oral calcium supplement as indicated, or we may need this IV calcium glyconate. So the special concentration is 12 kg used for the low dose of ACT-A with the heparin. So calculation of the estimate total blood volume for the pediatric patient, they will have the large volume of the more than adult. For the newborn is will be the 70 ml per.
Can you switch off the microphone? Okay, go ahead, Ufika.
And for the infant is 80 ml per kg, and child for adult is 65 to 70 ml per kg. This is toxicity management. As I told earlier, they will have this hypovolemia and they will have this thrombocytopenia also. So asparagus, because of the pediatric, they are sensitive to the fluid shift and the volume changes. So after procedure, we need to maintain the weight, and after procedure, and do not give any rinse back. Sir, can you give next one? Next slide. So pediatric asparagus toxicity management, thrombocytopenia due to low platelets because of this apheresis machine. So the child will be observed for this, sign and symptom of bleeding. So opting procedure will do the CBC. If the patient is undergoing like autologous HPC apheresis, so the patient will be need to transfuse, may be necessary prior for the removal of the catheter. So pediatric apheresis P, experienced apheresis staff to they will have this knowledge about the SOP for the pediatric patient, and they should educate the patient and the family member, and the child life specialist, and will provide the music therapy or therapy. So next is PBSC collection technique. So mobilization, the growth factor, they will need GCSF, granulocyte, GMSCF, chemotherapy or the growth factor. So we'll send this WBC counts or CD34 counts. So they will need this large bore IVSS or apheresis catheter. So it will be easy. So PBSC collection apheresis. So continual circuit like outflow, catheter, and inflow. That one picture is not there. PCV collection associated race. The line related, like they will have infection or thrombus. They will lose the platelets counts, calcium, phosphorus, magnesium, potassium, and some patient they will have this psychological effect implication like anxiety. Bleeding will be there, and multiple, if it's multiple collection. So PBSC collection, nursing assessment and intervention. So assessment, the blood count, vascular assess like venous assess. So fluid status, monitor vital sign, use anti-guidance and planning. Encourage to take more the calcium intake and transfuse when it's necessary. So next is umbilical cord blood. So limited will plan for the cell dose. So less indicate for, it is less in the incident of the grade 3 or grade 4 GVHD compared as the bone marrow and the PBSC. It is increase in the time to engraftment and decrease in the viral exposure. It will be affect the genetic disease. It will be risk. So UBC collection is associated donor risk. So they will have the lower hemoglobin in the no-need and infection disease testing of the cord blood. So UBC collection, this is assessment and intervention. Is we are not involved for the collection of the UCB and family education regarding UCSB collection and storage, and serve as community resource. So next is donor lymphocyte infusion, is called as DLI. So here is utilized for the allogenic HPCT. It is enhanced for the graft versus leukemia effect. It is leukocytes are collected for the original. We collect for the original donor and given to the recipient. So the major complication of DLI is GVHD. So optimal cell composition of DLI product, the low dose of the total molecular cell is CD3, recipient weight into the dose. So we escalate the function can be limited for the VHD and is still induced for the CVL effect. So the donor is required to required to go through the pre-evaluation prior to collect process, like maybe require the GCSF, they will not require, and the recipient may or not required for the chemotherapy for the prior of DLI. So HPC collection, bone marrow harvest, peripheral stem apheresis, and the cord blood. A pediatric patient may be challenges more, so proper knowledge and supportive guidance we should give to the patient and the family members. That's also.
Okay, Ufika, thank you very much.